Thank you, Manos and Manos, for the invitation. Dear colleagues, I think this is a great course with a very good scientific content. I enjoyed it yesterday, and I hope that we will all enjoy it also today and tomorrow. I have nothing to disclose regarding this presentation. So this is a huge topic, posterior-superior rotator cuff tear, and many things have been already said this morning, and we will have some discussions and some presentations also later on. So I will pinpoint just a few, I think, very important things about the management of the posterior-superior rotator cuff tear. So, do we need to operate those rotator cuff tears? Of course, we have a tear, so we have to fix it. But seriously speaking, we have some studies which shows us that the operative treatment is no better and does not protect against joint degeneration, and that there is no big difference in functional outcome, and that significant differences, but some studies shows also that there are some differences in pain and disability between conservative and operative treatment. In this meta-analysis, there was shown that there is a limited evidence that surgery is not more effective in treating rotator cuff tears than conservative treatment. Still, there is a trend to the surgical option regarding the constant score and pain. But this is valid for small, non-traumatic supraspinatus tears in patients older than 55 years, so non-traumatic tears. And we know that we already heard something about the natural history. So there is a tear size progression, and they might become irreparable within several years. And we also know that predictors for tear progressions and muscle degeneration are pain, larger tear size, and disrupted anterior rotator cable. So, if we choose conservative treatment, we have to know what are we dealing with. So, if we have a patient, I suggest to follow up him or her with MRI every 1 or 2 years, or earlier if the patient has a pain. And you already saw a similar case. So this is in 2018. You can see the upper pictures where we have a reparable rotator cuff tear, and after 2 years there is a completely different situation. So we can opt for conservative treatment, but in the cases where we have low risk of clinical progression and where there is a poor potential for the tendon healing, like, for example, in elderly population or not so demanding patients. But if we have acute traumatic tear, and when we choose conservative treatment in those cases, we have some studies which reports on these results. We can see that there is a considerable early failure rate in more than half of patients. And patients with multiple tendon torn tears are more likely to fail. And also that the tear retraction has no influence. So the satisfaction rate in those patients is better with operating treatment than conservative one. Does delay matter? According to this article, we can say that it does matter. It is a small group of patients in both sides, but they show that there is a higher failure rate in the delayed groups, even there is only 3 months delay. When we come to surgical treatment, which is our goal, or we are thinking about the surgical treatment, so in this systematic review, comparing arthroscopic with open and mini-open, they show that there is no big differences in functional scores, complication, and retear rates. So all options of the rotator cuff repair are viable. This is one of the first reports on the surgical treatment and results, and I think that Some small things are changed, but not many of them. So we know that not all of the rotator cuff tears they are repaired are healed, but the patients usually do well. But of course, if we have integrity of the cuff, those patients do much better. Are we coming better in during the time? Yes, a little bit, but we have still a problem with healing rate. So we have some factors which impact the outcomes, and there are some factors which we could modify and some which we could not modify. And we are all familiar with those. So we have to do, we can do something with, for example, with those modifiable risk factors, but nothing according to age and so on. We know the predictors like muscle fatty degeneration and atrophy and so on, but I would like to pinpoint this, that tendon length is also important. According to this study of Gerber's group, the tendon length is a more powerful predictor of repairability than Goutalier grade alone. So if we have a short tendon length, then we have a much higher failure rate. This is for the Goutalier tip grade 3 and also for the lower Goutalier stages. So we have this clinical problem of healing, and the problem is that the normal enthesis is not reestablished, and the weak link is tendon-bone interface. So normally we have this very good architecture of the tendon-bone interface with the bone, fibrocartilage, which is mineralized and unmineralized, and then the tendon. But when we observed our rotator cuff repairs, there is a scar tissue which is disorganized, and it is not organized like on this on the left side. So why does the tendon fail to heal? Because there is inadequate number of cells. Maybe the environment is not good, so we don't have the proper signals. There is a poor vascularity, or there is imbalance between degeneration and synthesis of the matrix. So how we could improve? On one side, we have a mechanical possibility for improvement and biologically. And while we continue to study biology, as a surgeons, we should optimize the mechanics of repair. We know that different configuration has a different biomechanical results. And I will not go into details about the single row and double row because there will be a big discussion about this later on. But the main principle, I think, and what is very important is that we have to opt for the tension-free repair, because the possibility for repair increase where there is a tension, it causes a pain, discomfort, and also reduction in blood flow. And if it hurts the fingers, the suture, then it's probably hurting the tendon as well. So what is, for me, the main principles of the repair? First, you have to visualize the tear, at least for the, two different portals, and I think that the lateral portal is very important because only in this we can see the delamination. Then we have to adequately mobilize to achieve tension-free. Then we have to check the reduction. So we have to be very sure how to lower the tension and what is the good reduction of the tendon. We have to recognize the tear geometry. You are very well familiar with this Burkhardt classification. We have to expose the landmarks if we need it. We have to know what is the muscle orientation. This will help us for the reduction. We have to identify and address delamination, and finally, we have to achieve secure fixation. For me, this is just equally important as question of the rows, single row or double row, because this is really a basis for the repair. We have some augmentation principles, and there will be some talks about the augmentation as well. And this is really a change in principles in the last year. A few years ago, the first thing which was done when we come into the joint was to kill the biceps. Now we preserve the biceps and to see if we will use it or not. The next important thing is bone bed preparation. There are some evidence that the healing rate is greater if we prepare the bone footprint with abrasion and bone marrow vents, and also maybe with nanofractures like Miguel showed us in his study. And also we have some possibilities to observe a neotendon on the lateral part of the tuberosity. But are we prepared for the next stage on the bone bed preparation? Because there are some articles and there are some evidence that remnant preserving philosophy is maybe better and will achieve a better healing rate, because the presence of the fibrocartilage at the bone-tendon junction is also associated with the nature fibrocartilage preservation. If we preserve fibrocartilage, maybe this will give environment for the better healing and for the better architecture of the tendon-bone junction and the healing point. But we cannot go over the costs, because the costs of all new techniques and augmentations and biology and so on can be really high. Also, the number of rotator cuff surgeries is higher and higher. So we have to optimize our treatment, and there is still some work to do for us. We have some difficult case scenarios. In small tears, everything will work, but it is difficult to decide, and this is it should be matter of discussion, what to do with asymptomatic young patients, what are the limits of repair in acute repair tear with retraction, in elderly patients, what is the time limit for repair, and what are the indications for augmentation. We know that the tears get bigger with time, that smaller tears more reliably heal, that there is an impact of the age and atrophy and tear size. And this Yaga-Scott consensus shows us that some things are very clear, and there is 100% agreement on some points. But we still do not know, do healed tears stay healed? Can we change the natural history with reconstruction? What is the best repair construct? And can we influence biology? Thank you so much for your attention.